Okay, you're good.
All right, guys. So welcome back. Thanks for all of you who are joining us for another interactive session today. We're going to be talking about tibial shaft fractures. We're going to do a couple case presentations, go over some of the basics, and then get into a little bit of the nitty-gritty and some tips and tricks for more challenging fractures. We're going to try to keep it simple from the start to make sure we cover our bases, and then you guys can certainly ask questions as we go through this. So case one, this is a 52-year-old male, pedestrian struck. No pertinent past medical, surgical history other than diabetes. Here's his x-ray. Does anyone want to describe this x-ray for us?
You have AP
What
and
you see?
AP and lateral tibia film, skeletally mature individual.
Nice.
There's an oblique spiral fracture of the tibia and a midshaft segmental fibula fracture.
Nice.
I'd say
excellent.
Before you go ahead, you see anything more proximally? Maybe look at the lateral. I think you can see it a little bit better there, or at least something.
So this might be segmental as well, the tibia.
Yeah.
Nice. Good catch. Good pickup. What side? Just take it a step further, Lisa. You crushed the first part. So what side do you think the energy came from, medially or laterally?
It depends if it came distally or proximally. Probably hit like the lateral mal and did like a rotation.
Yeah, I think the force came from laterally. And one of the things we talk about is we talk about bone failing. You know, how does bone fail? Does bone fail in tension and compression? We talk about the tension and compression side of bone. This does have a spiral component to it, but it also has a bending component to it. And you can see that there's a butterfly fragment here laterally, right? So that could mean that's the compression side, and that's likely where the force came from to some extent. But I think you can certainly be right about some sort of rotational mechanism with a spiral fracture. But this is a high energy injury for sure. Here's a splint films. You know, for when you're splinting the tibia, you know, you want to try to get it realigned, but this is obviously an operative tibia. This is not something that you're trying to get into a cast and treat this non-operatively. So you're not going too crazy with the soft tissues. You're realigning the limb for patient comfort pending the operating room. Any other imaging you guys want to get?
If you're worried about it going to the ankle, you could get a CT, but your block is where I would look, your text block. So I can't really tell.
Nice. Okay, a CT is good. You want to make sure, so you want to evaluate, if you want to evaluate the articular surface somewhere better, you get a CAT scan. One of the things you could also consider is with the segmental nature of the tibia here, you want to make sure that there's no extension intra-articularly, right, for our nail placement. So we got a CT of the knee. Here's the tibial plateau. You see there's no fracture here, so that's good news. What about the ankle? Anybody see the ankle fracture?
Yeah, the medial mal, yeah.
Fracture. Yeah, that one got me too.
It looks kind of old, doesn't it?
No, I don't think so. It was acutely tender there. But so it's something to think about, right? And so kind of considering our order of operations, we'll show you kind of what we did. Just keep it in your mind about what you think, how you would want to approach this, and then we'll kind of go through it at the end. So, all right. So Lisa crushed all these answers. High energy, probably laterally. Direction we got. Does an intact fibula change your risk of malalignment? One of the things we talk about is an intact fibula. Sometimes you have a risk of a increased varus deformity at the tibia here, and so it can sometimes make your nailing a little bit more difficult. So kind of a free floating tibia. And so, you know, we want to realign the limb well prior to fixation. So we'll go through those steps here. So I stole this from Jeremy.
Before you go on,
Yep.
when you see like a segmental injury, what do you think about like similar to mechanism? Is it high energy, lower energy?
High energy.
High energy for
Can it
sure.
automatically become like a type 3?
Type 3 what?
Gastio Anderson? Like regardless
Well,
of
this isn't open.
Okay.
But you're saying with the high energy, could it be treated as a Gastio type 3? Sure. I'm not so sure that that's universally accepted, but it's certainly a worthwhile consideration.
You guys X-fix this?
Nope. Fixed it, baby. All right, so starting point. So we start, you know, this is a tibial shaft. This is relatively mid shaft, a little on the proximal side, but you start just medial to the lateral spine. And we talk about starting anteriorly adjacent to the joint here. And so one other thing for you guys, do you want to nail this with an infrapatellar or a suprapatellar starting point? Is one better than the other? Any pros and cons of each? Anybody have any thoughts?
Suprapatellar, I know, has a faster time to union and to weight bearing than if you do parapatellar.
I hear a couple people talking. So Kate was talking about a possible earlier weight bearing and some better outcomes.
I think
Vivek, I think you were talking too.
The suprapatellar nailing, I think you have improved like alignment of the fracture, according to what I read.
Okay, that's a reasonable consideration. You're talking about having improved alignment of the fracture. You know, Jeremy's going to talk a little bit more about the semi-extended nailing position in his proximal tibia fracture, relieving the deforming forces on the knee here and on the tibia. Honestly, there isn't any difference, any major difference between the two starting points necessarily if you're mid-shaft. However, there are some pros and cons to each. In our case, we chose a suprapatellar nail. One of the reasons that we chose that is because we place a bone foam under the leg, which I'll show you guys. And if you're gonna, you know, this is a segmental injury. This is one that we might want to place a clamp around. And so if we're going to do that, what you can, with an infrapatellar starting point, you have to place the knee flexed pretty high on a triangle. And it can make it a little bit of a challenge radiographically to check your alignment with fluoro intraoperatively, especially when you're placing that clamp. And so being able to, you know, and certainly either one can be used. I think that's important to point out. But in this situation, it made our imaging nice that you could swing to a lateral, swing to an AP, and you don't have to really change the position of the limb while your clamps are on and you're holding that reduction. And so that was one of the things that we chose. Now, keep in mind that you have to have a general idea to evaluate the patellofemoral joint preoperatively to make sure that that joint is likely to accommodate a suprapatellar nail starting point, right? If a patient has severe arthritis, they've got a really narrow joint space there, and you're concerned that you might not be able to get a suprapatellar starting point, that's something that you have to keep in mind and evaluate beforehand. So this was a patient that had a fairly robust space here, fairly mobile patella, and so we thought that it was appropriate to use that suprapatellar starting point. Here's an image. This is just a cartoon picture, but this is what I was talking about. The leg's a little bit more flexed than this for us, but essentially by placing the leg on this bone foam, you know, you can swing back and forth on the AP and lateral, and you don't have to put it high on a knee triangle like we were talking about. So this is our, there's a cartoon version here, this nice incision here. Make your incision above the patella, above the suprapatellar pole. And so you're making your incision through the skin, sub-Q, and then going down, splitting the quad down to the patellar tendon, or to the patella, sorry, I should say. This is just a schematic here for you guys to have an idea of how we set this up. This most modern patellar systems, when you're using suprapatellar nailing, utilize a silicone or some type of less irritating type sleeve. And so early on, there were some studies when you used a metal type trocar that there was some cartilage damage, makes sports guys like Jeff cry. And so, you know, with the advent of the silicone type sleeves, this is theoretically diminishing that risk of damage to the cartilage. And so this is your insertion sleeve, your drill sleeve, the handle, your trocar, your plug. We're going to go through kind of all these steps. These are important to know. It may be 3 in the morning and you've got a technician that's never used the nail. You as the surgeon, you need to know how to put all this stuff together and use it well.
Judge,
So this is after we've made our incision. Yep.
I just want to point out just one other thing with suprapatellar going through the knee joint. There used to be talk about increased risk of septic arthritis following it, and that's have proven to be not true. So it doesn't matter intrapatellar or suprapatellar, the rate of septic arthritis is the same.
Nice. So this is after we've assembled our trocar here. We placed it underneath the patella here. You can see you've got the handle and you've got the insertion sleeve for your guide wire all in place here. And so what you're going to do, we're going to plan to slide the guide wire through just to the edge to give ourselves radially something to look at to confirm our starting point. Here's intraoperatively. You can see medial to the lateral spine here. It's a little bit medial, but it's in a reasonable position. Looking at the lateral x-ray, you can see that we're starting just anterior to that articular surface here, and we were satisfied with our alignment of the wire prior to using our opening reamer. So what you have to do, this is the system that we use. There are many systems that are great to use, but this particular system and many of these systems will have some sort of wires. I don't know if you can see my mouse, that can be inserted to kind of hold that sleeve in place. So while you're doing your work and you've gotten your alignment, you don't want that moving around on you too much if you can not have that happen. So this is a schematic showing what it looks like to have these wires placed in, these 2 wires medially and laterally, and then your guide wire placed in here. The next thing you're going to do is utilize your opening reamer, open up the canal here proximally. And so next steps, you're going to remove our opening reamer and insert your ball tip guide wire. Now, keep in mind that we talked about the possibility of clamping. We talked about the possibility of realigning the limb in some way to improve the alignment. Remember that you want to do this work before you start reaming. Whatever you ream, once you start reaming, that's going to be your final position. You're not going to do any correction after that, or you will be unsuccessful in getting the results that you desire. So before we start reaming down the canal, this is when we began to place our clamp to try to get the alignment a little bit better. Once you do that, we'll then begin sequentially reaming. This was just a fluoro shot at the ankle showing that you are relatively centered with your ball tip guide wire. Usually we put a little bit of a bend in the guide wire, which will allow us to kind of, you can bounce the wire off the cortex to kind of aim it to the trajectory or the spot that you're aiming for. And then the other thing is that it allows you some rotational control and visualization, understanding of your position of the ball tip guide wire. We don't put a big bend, but there's a little one here. So I don't have any fluoro saved of the reaming portion, but I wanted to point out this side-by-side fluoro to you guys. This is on the left. You can see we were able to pull traction and get a pretty nice reduction, but you can see that there's still a little bit of valgus here of the tibia. And so to make that better, we placed our clamp here percutaneously utilizing our Weber clamp. And so, keep in mind that we're not chasing after that butterfly here, right? We're going after the 2 large cortical pieces that we can realign the limb with. And that's the inframedial and the supralateral parts here of those tines that we're going. And you can see that it improved the alignment considerably. This clamp is kept on for the duration of the reaming like we talked about. You want to do all of this work before you ream. And then this is the image showing before you can put the nail down and keep this clamp on till the very end if you can.
And
It's just a
Joe,
lateral showing the, yep.
it's important to note that these clamps and reduction aids can always be used in a percutaneous manner. We always think about nailing as a closed procedure at the fracture site, but there really is it's not just black and white where it's either closed, there's either no reduction or it's open to devitalize the bone, strip the periosteum, and apply reduction forceps. You can use things percutaneously to maintain some of the goals and things we like about nails, such as the fracture biology, but still maintain your reduction long enough to get a implant in place.
That's an excellent point. And there's more than just this available. I didn't want to get too technical on some of the things, but there are other options such as a small 2-0 plate or tubular plate that you can place temporarily on one side of the fracture to reduce it. You can utilize, some surgeons can utilize a variation of an X-fix or a distractor. I saved some of those, I think, for future talks, but that's an excellent point, Jeff.
Why don't you?
This is just one thing I wanted to point out when you guys are the medical student in these cases. This is the obturator. Make sure you get this in your hands because as you start to ream back and forth, you want to be able to hold that ball tip guide wire in place. So I always put this in the lecture. Vivek, did you have a question?
Yeah. So the butterfly fragment. Do you just disregard that when you're nailing?
In this case, yes.
So, Vivek, if you go back to the original, like some of the first series lectures that we did, I don't know if you had a chance, if you were on any of those, we talked about different types of bone healing, different types of goals of fixation and constructs. So intramedullary nailing is a form of relative stability. It is a form of it's a relative stability and a functional alignment in terms of length alignment and rotation. It's not an anatomic reduction with direct compression and primary bone healing. So you do expect to see callus with bone healing. So in order to put that little butterfly back in place, you would have to do a lot of soft tissue stripping in order to get over to it and maneuver it back in place. And then even if you could obtain that reduction and put the butterfly piece back in, how would you secure it and fix it and maintain the reduction? So if you were doing an open approach and doing a plate fixation of this, that butterfly fragment would be paramount and you would have to key it in and you would have to compress it. But this construct doesn't need it at all.
Yeah, I think Joe's last point about you can get it reduced with a clamp or whatnot, but once you release that, there's nothing holding it. The proximal and distal shafts, those are going to stay in place because the nail's holding those in place. But that butterfly fragment will just move back to where it is now.
Nice. That was a great explanation. This is just another schematic. Just want you guys to be able to see it. Some of the things when you're assembling your nail, the strike plate, which is what you'll be utilizing to hit with your mallet, the nail holding screw, the adapter, and the targeting arm, which is going to help you with your interlocking screws proximally. So once we've done all the things that we mentioned, we were happy with the, I forget what size nail we used, but you've reamed up to 1 to 1.5 millimeters greater than your anticipated nail size. You're going to put your nail down. Again, this is a nice cartoon drawing here, putting it through the sleeve. If you notice, just don't forget, I did this the other day. I grabbed the nail before I took the inner metal sleeve out and looked like a dummy. So make sure that you remember to do that before you send your nail down through the silicone here. This is just a lateral, and so this is something that you'll see. You're trying to look at the depth of your nail and that you're seated enough. And so if you look kind of here, you can see these kind of convexities here. And so this is the end of your nail. So you know that this is not penetrating out through the articular surface. You know that when the knee is extended, it should not cause painful symptoms. And so I just wanted you guys to appreciate that level there and where the nail is seated. This is very quick, just the targeting arm. We're not going to get, I don't want to get too nitty gritty into the different types of locking and trajectories that you can utilize, but I just wanted you to appreciate the targeting arm and that you can lock the screw proximally in various ways. Just here, we talk about what stricture lives past the tip of our screw. You probably love to not plunge here. You don't want to go at the perineal nerve. And then one thing that Dr. Sirkin actually pointed out, which was interesting in this case, was he said, if you're using the anteromedial to posterolateral interlocking screw, which is going to be a little bit more proximally in the nail on that targeting arm, what is one of the symptoms or issues that can arise? This is probably like a Jeremy or Joe Galloway question. Or Jeff.
So if you're placing in a screw that's in a trajectory from anteromedial to posterolateral, you're starting in a very subcutaneous position with that screw. And one of the issues that can arise, especially with Stryker's implants, and this is not a company-based talk, is that their screws happen to be very prominent, and so that can wind up being a very prominent implant on the anteromedial face of the tibia.
True. Yep, that was what he said. And the other thing he mentioned is the possibility of irritating that proximal tib-fib joint. And so it's just something to be thoughtful of and conscious of if you're using that type of a nail trajectory. This is just going to be a quick little snippet of perfect circles. I know you guys continue to advance and get more deeper into your rotations and all that, and so some of this may be redundant, but I wanted to just show you this real quick. This is when you're placing your interlocking screws distally. You're utilizing a perfect circle technique, which is essentially putting the screw through bone, through nail, through bone, and kind of how you line this up. So this was I stole some of this from a YouTube video by Dr. Ben Taylor. It's a great video. He had some nice fluoro shots to demonstrate some things here. So this is a lateral x-ray. You can see this knee is in an extended position here. Looks similar to what we would have on a bone foam. You have your fluoroscopy up here, taking a lateral. And so what you're trying to do is you're trying to bring these holes together. You have the medial cortex, the intramedullary nail hole, and the lateral cortex. You want these holes to line up, right? And so what you basically wind up doing is you're going from medially to laterally in your distal interlocking screws. And so you're really focusing on these two holes. This is your medial cortex and your intramedullary nail hole. And you want to line up these holes. And once you line up these holes, you know that if you've got those two holes lined up, you're going to have cortical bone on the other side that you'll be able to get purchase in. And so this is kind of my bootleg schematic here. So if you take a look at this fluoro here, you can see that the holes are off in multiplanar directions, meaning that they are
Yeah, freeze for everybody.
Yep.
Yeah, so he's trying to point out that there are ellipses in both planes, so it's kind of oriented obliquely in its ellipse. So you know that that's off in both planes. So the best way to do it is try to correct one plane at a time. So you have to either do wig-wag, which means either abduct or adduct the leg closer to the fluoro screen.
Joe's got his hands up.
And then you can work on rotation as well. But you have to adjust both of those. But it's much easier if you just try to do one at a time.
You can illustrate this for yourself just by looking through your two hands like a periscope. And if you think about Up, down, and side to side are your two planes that you're trying to work with an x-ray. And imagine that they're off in a 45-degree oblique. Then how are you going to get it in? And if you're thinking about moving a fluoroscope or a C-arm, you can't just dial it in immediately. It takes a couple of moves. So the simplest way is to break it down into quadrants. And so you move the base of the C-arm and you adjust the angulation, or what we call the wig-wag, and then you adjust the angulation of the C. So you work it up in one direction, and then you work it in the other direction until you can see straight down the center. And instead of seeing a football or an oblique, you see a perfect circle.
And keep in mind that the X-ray beam from the fluoro is essentially a line of sight. So the direct line between the beam and the receptor plate is what you're seeing on the screen. So additionally, that'll be an external guide for you as well once you start to know exactly where, once you have your perfect circles lined up.
Yeah. And you can do it two ways. You can either manipulate the fluoro machine itself and have the X-ray tech move the machine to line up the circles, or you can move the limb itself. I personally like moving the limb because then that way I keep the fluoro machine parallel to the floor, and then I can keep my hand in that position. However, sometimes if you have to manipulate the leg too much, then it's like falling off the table or not. So sometimes there's a happy medium.
Depending upon your particular fracture morphology and what you're trying to do, especially in femur fractures where it's a little bit tougher trying to tell the rotation, and you're going to then determine your rotation both based on images and the lesser trochanteric profile. In those I've seen Dr. Riley, and especially when I've done with Dr. Riley, he prefers to move the C-arm instead of the leg, so that he doesn't have to manipulate the distal portion of the femur and mess with the rotation of the femur around the nail. So then he can assess where it is and then manipulate the object in space. So there are pros and cons to whether you move the leg versus whether you move the fluoroscope.
Good point.
Nice. Sorry, my wife used the blender and somehow killed the internet. All right, so.
Hey, Steph, can you use the blender for us as well?
You making a protein shake? Trying to get the gains.
Yeah, bro. All right, so Joe described it, and Jeff, and you guys all described it really nicely. Good pearls. We know that this is going to take, like Joe said, this is going to take in one direction. You can wig-wag this and get the circles better, right? You can tell here that this needs rotation, right? So it's not that the holes are proximal and distal to each other, it's that they're anterior and posteriorly off. So let's just look at those one more time, right? This is something that needs wig-wag. This is something that needs rotation, right? To improve your perfect circles. And this is what you're looking for, right? And so, Joe really nicely described some different pearls and pros and cons to some of these things. And Jeff described really nicely the getting your drill aligned with the beam of the fluoro machine. Sometimes if you've got a laser, depending on what side the fluoro is coming in from, you can kind of line the laser up kind of in the hole of your drill and know that you're kind of on the correct trajectory there. You're drilling bicortically here, obviously. This is just one of the fluoros showing the placement of the interlocks and using our depth gauge. And then just at the end of the case, percutaneously, 2 cannulated screws were utilized here. And I don't want to get into it too much, but Dr. Sirkin had kind of a nice trick. He talked about the strongest bone here for a medial malleolus fracture fixation being kind of at that shoulder there. And so if you're planning on utilizing lag screws, either lag by technique or lag by design, when you're trying to template, if you're using lag by design type screw, which is a partially threaded screw, what he'll do is he'll lay that screw over the medial malleolus to make sure that the lag screw can get, or the threads can get past that fracture line. But as he basically kind of cheats these on the shorter end to make sure that your in the most robust area of fixation that you can get, unless you're going bicortically. Because if you send screws and you leave them, I don't know if you guys can see my mouse, but in the middle of the metaphyseal bone, they won't have great purchase. I thought that was just a nice pearl. Here's the final product. This patient was made, weight bearing is tolerated.
And again,
That's it, boys.
elaborate on what Joe Galloway was saying, we're just looking at getting our length, alignment, and rotation correct. So when we're looking at something post-operatively, we're just checking our alignment, our length, and the rotation. So I think it looks nice.
Jeremy, you want to take over Sharon here?
One thing that's difficult, or difficult's not the right word. How do you decide what the right place it is? We talked in prior lectures about what the right rotation of the femur is, and we try to, when we don't have a good cortical read or we don't have any reliable landmark to set our rotation on, we choose to set it to the contralateral side. And we know that we're not that great at it, even though we have a form of doing it by assessing, like we talked about last time, the lesser trochanteric profile, where we use x-rays of the other side and we try and make the x-rays of the side we're working on look just like that. But in the tibia, it's sometimes even harder because the rotational images don't turn out so well. So commonly what we rely on is normal values, which have been established for population norms. And so a lot of what we do is based on the work of Dr. Paley. So if anybody is interested in, what you'll find is you'll find these little diagrams. You see them all the time. You see like the lateral distal femoral angle. You see the proximal medial tibial angle, the distal tibial angle. You see all these things. You'll see these little diagrams if you look in orthopedic textbooks. And all of those are based on what we expect the normal angle of joints to be, based on an analysis of population norms. And so that's what we're doing when you're looking at these x-rays here. These are nice x-rays that Joe has. Look at the tibia plateau, the top of the tibia, and look at the joint there and how that alignment relates to the bottom, the very bottom. Just completely ignore the entire tibial shaft in between and look at the tibial plafond and how did those two line up relative to one another. And then same thing on the lateral. And that's what we're focusing on. We're completely ignoring all of what's in between and just trying to make the joint surfaces line up what we assume to be correct to one another.
Nice. Jeremy? I think I might have to re-log in. It's about to crash.
All right, let's jump to the second case. So this is a 62-year-old female, and she had a large object that fell on her leg, and she came in with lower leg pain. Had diabetes, but the remainder of her medical history is negative. These are the images that we got in the trauma bay. Does anybody want to just take a quick shot at what you see?
I can give it a shot.
Sure.
It's an X-ray of right leg AP and lateral view in a skeletally mature patient. There's a fracture of tibia at metaphyseal diaphyseal junction with a proximal fibula Maisonneuve type fracture.
Yeah. And what do you think about the alignment of?
So there is on lateral there's angulation as well. Anterior angulation can also be seen, as well as even on the AP there's slightly valgus angulation.
Yeah. Yeah, no, perfect. I think you hit it right on the head of the nail. So I agree with you. It's a proximal third tibia fracture. And so is that deformity that we have, this valgus and also apex anterior or progravatum deformity, is that normal for proximal tibia fractures? And the answer is yes. So they all, not all of them, but the majority have this, and you have to pay attention to that and